In this video, we're going to follow blood through the body. Okay, this is the picture you're most familiar with the heart and lungs. So all I did was blow a heart up, straighten it out, and make it easier to understand. My box actually came from my preceptor when I was a new grad. She would show the patients how their heart worked on the back of the Kleenex box. So this is really just a giant Kleenex box. But let's start with the picture you're most familiar with. We'll follow blood through the body. We'll start the blood in the lungs. It'll leave the lungs as arterial and get pumped throughout the body. So we'll follow blood through the body. We'll start the blood in the lungs. It'll leave the lungs as arterial. Now, initially, the arteries and veins, when they're close to the heart, are very large. As it gets further from the heart, the arteries and veins are going to get smaller and smaller. So first we'll go to our toes. So the blood comes out of our lungs as arterial, and it gets pumped all the way to our toes. And then we come to this guy, and this amazing thing happens at the capillary beds. The arteries magically turn into veins. Such a cool organ. So we get all the way to our toes, and at the capillary beds, the blood magically turns into venous. So the blood returns to the heart as venous. Then it goes to the lungs, where it gathers oxygen, gets rid of CO2, and comes back as arterial. Now we'll go to our fingers. Whee! And it will come back to the heart as venous. My box is the same picture. We'll follow the same pattern. We'll start the blood in the lungs. It'll leave the lungs as arterial, enter into the left atrium, then get pumped into the left ventricle, and literally get pumped throughout the body. At the capillary beds, it'll magically return to the heart as venous. It'll come back to the heart as venous. It'll go to the right atrium, then it goes to the right ventricle, then it goes to the lungs where it gathers oxygen, gets rid of CO2, and comes back as arterial. Our heart is two completely separate systems pumping simultaneously. This side only pumps venous, this side only pumps arterial. What keeps them apart is our septal wall. Some parts of the hospital call the heart the load. The heart itself is the load. So if this is the load, this is preload, or your CVP. And this is afterload, or your SVR. The load itself is the heart. Now, blood will flow like gravity from top to bottom in the heart, but the heart itself beats right to left. When the atriums contract, they contract together, and when the ventricles contract, they contract together, and when the valves close, it makes noise. So what you hear is lub, dub. And all you're hearing are the valves close. When the atriums contract, they'll contract together, then the valves will close, and then the ventricles will contract together, and the valves will close. When we talk about cardiac output, we measure two simple things. Cardiac output, you're going to take your patient's heart rate or their pulse and multiply that number by times their stroke volume. What is stroke volume? With stroke volume, they're usually referring to your left ventricle. It could be your left or your right, but usually when they talk about stroke volume, they're talking about your left ventricle. Stroke volume is how many cc's your left ventricle puts out every time it squeezes blood. How much volume per stroke. You'll only know a patient's stroke volume if you have a very recent cardiac cath, echocardiogram, or MRI of their heart. So in other words, you're not going to know very many of your patients' stroke volume, but you're going to know everyone's heart rate. Since you know their heart rate, you're going to know everyone's heart rate. Since that's the part of the formula you know, when you control someone's heart rate, you're actually going to control their cardiac output. When you measure cardiac output, you measure two things: your patient's heart rate or their pulse multiplied by their stroke volume. I'm going to imagine we're all average adults. Right now, I assume you're resting. Your resting heart rate is 70 beats per minute. On average, every time an adult heart squeezes blood, you're going to squeeze 70 cc's of blood. So if your heart rate is 70 and every time you squeeze blood, you squeeze 70 cc's, in 1 minute, you're going to move 4,900 cc's or 5 liters of blood effortlessly. You won't know their stroke volume, but if you're enjoying a heart rate of 70 and it's because you squeeze 70 cc's, what if I drop your heart rate to 40? You're not going to like that. If you have, say, a patient with a heart rate of 40, they're going to complain of acute coronary syndromes. They're going to complain of chest pain, lightheadedness, dizziness, shortness of breath. If my heart rate was 40, I'd probably be nauseous. I might even throw up. But if you put it back up to 70, all those bad things would go away. Now, if you were on a treadmill and say you were exercising and you're in sinus tach and your heart rate say is 120, 130, no one feels sinus tach. If you were on a treadmill next to me and we were exercising and we were talking, you wouldn't feel that you were in sinus tach. You'd feel short of breath. This is short of breath. Pretend you and I are talking. We're going to the movies this weekend. Short of breath means they can't finish a sentence. It makes perfectly good sense to be short of breath when you're exercising. It makes no sense to be short of breath at rest. If a patient ever tells you they're short of breath, and they will, or appear short of breath, they can't finish a sentence, they're talking in simple words or a few words linked together, it sounds like something very bad. It sounds like nasty COVID. It sounds like a big nasty pulmonary emboli or a big nasty heart attack, an MI. So if a patient or anyone ever tells you they're short of breath at rest, take that very seriously. If you have to call 911, send them to the emergency department. Once we get a 12-lead EKG, we can diagnose the PE and the MI. And if you stay shortness of breath, we'll get a stat portable chest x-ray. But take that very seriously. But if you were exercising, you wouldn't notice you were in sinus tach. But say someone gave you some weird medicine and your heart rate was now 220. Your resting heart rate is 70. Now it's going 220 times a minute. You're not going to like that either, because your ventricles are pounding away 220 times a minute, and there's not enough time to fill with 70 cc's. So when the heart rate is too fast, you decrease cardiac output because you decrease their filling. Either way, I probably won't know my patient's stroke volume, but if I control their heart rate, I control everything. Just also know by the end of today, you're going to take well over 20,000 breaths and not notice most of it. Your heart is going to beat well over 100,000 times just today, and you're not going to notice most of it. We are an awesome autopilot machine. We really are. What actually controls our heart rate are our 3 pacemakers. We have 3 pacemakers. Now, we're so big compared to infants, and we can produce so much stroke volume. Your SA node is your natural intrinsic pacemaker. At our age, greater than 16 years of age, adults, you can produce so much volume. Your SA node will give you a guaranteed heart rate of 60 to 100 beats a minute. Normal sinus rhythm. That's why I bet if you're watching this video, you're in normal sinus rhythm. I assume you're over 16 and you're an adult and you have a functioning SA node 60 to 100 beats a minute. Something bad might happen to someone's SA node. It might quit with old age. It might get fired with a heart attack. If that happens, your AV node and the bundle of His are going to pace you. But your AV node and bundle of His will only give you a heart rate of 40 to 60 beats a minute. You may or may not even mind a heart rate of 40 to 60 beats a minute. But if that bad thing, say, wiped out your AV node and bundle of His, your Purkinje fibers will come and pace you. But they're very slow. Purkinje fibers will only give you a heart rate of 20 to 40 beats a minute. And no human on this planet is going to feel good or look good with a heart rate of 20 to 40. They're usually gray colored. So just know if you have any human in front of you with a heart rate of 20 to 40, they won't be in sinus bradycardia, and you should be prepared to pace. So anyone in front of you with a heart rate less than 40, they won't be in sinus brady, and be prepared to pace. Easy.